Now, this is another study also from a Belleville community. Of these were free-living people who were studied in a study where they just went and found the people and looked at them. They were not looking for disease patients. And what they did was they grouped the people on the presence of non-alcoholic fatty liver disease, which is remarkable. This group of scientists in Cape Town had realized that non-alcoholic fatty liver disease has got something of high relevance in this disease. And they measured the blood content of gamma-glutamyl transferase, which is a protein which is released into the bloodstream. As the liver gets fatter, it releases this protein or enzyme into the bloodstream. And they were the first in the world to show that this is a good predictor of the extent of metabolic syndrome in individuals. We now know that it doesn't identify everyone with non-alcoholic fatty liver disease, but it's nevertheless a good marker. And what I want to show you is that they looked at most of the atherogenic markers in this population who were essentially healthy, living in Belleville, a few miles away from us. And so they looked at the variables, and quartile 1 is the group who had the least gamma-glutamyl transferase in their bloodstream. So they had the least evidence for non-alcoholic fatty liver disease, whereas group 4 had the worst evidence for it. And so they measured mean body mass, and you can see that even in this group who have the least, they're pretty heavy. They're not yet obese. Obesity is at 30 kilograms per meter squared, but they're on the border of obesity. This group is essentially obese, and those two groups are. So in this population, 3/4 are obese, which is a bit frightening. Here's the blood glucose. We need to explain that your normal fasting blood glucose is 5. And you keep the blood glucose low by secreting insulin overnight, and we would also measure your insulin concentration under fasting conditions. We would like to see the glucose at 5 and insulin below 10. What first happens is you start to rise the insulin. As you become insulin resistant, you could have a fasting of 5 and an insulin of slightly above 10. And I showed you, that was my experience in the data I showed you on myself, that my insulin was rising even though my fasting glucose was normal. Now, 5.9 is still, we wouldn't make a diagnosis of diabetes on that level, but here we would. So we would diagnose diabetes in this group. So 50% of this healthy population has already established diabetes. 50% of this free-living population in Belleville, on the most simple testing, have diabetes present. Now, they didn't develop diabetes last night before the test was done. They progressed, and this group will have, these two groups will also have people who are profoundly insulin resistant, and in a few years' time will be diabetic. The other marker we use for diagnosing diabetes is the HbA1c level, reported as a percentage, and that tells us what your average blood glucose concentration is over the previous 3 months. The best value to have is 5 or below, and then your risk of many diseases is least. We start to make a diagnosis of diabetes at a value of 6.5. So these two groups, again, half the population, have glucose levels which are so elevated during the day that we can almost really already make a diagnosis of diabetes. And these two groups are on the way. I tell people that once your HbA1c is above 5.5, you're in trouble. You need to cut your carbohydrates. What you see is this total population, 100% of the people in this group are on the way to diabetes if they haven't already got it. So they were not looking for diabetics. They were screening healthy people, and they find that. Triglycerides, as you can see, would rise, and that's a marker of insulin resistance, and you'd expect that. And the group with the most severe non-alcoholic fatty liver disease have the highest triglycerides. We know that a value below 1 or 0.8 tells us that you probably haven't got a serious atherogenic dyslipidemia. So all these people are at increased risk of atherogenic dyslipidemia and those small, dense LDL particles which were not measured. But once your triglycerides are over 1, you've got an increasing number of these small, dense, atherogenic particles. Here's HDL cholesterols, which in all groups are low but don't change very much. And here's the key. If these patients had not had these measures of insulin resistance measured, if they'd just gone to a doctor who had been trained to think only in terms of the diet-heart hypothesis and the lipid hypothesis, the doctor would have said, oh, your cholesterol's not too bad. It's 5.4, it's only 5.7. 5 is normal, 5.7, okay, it's not normal, but it's not grossly abnormal. When I was at medical school in the 1970s, we were told that 7.5 was the normal cholesterol. And as I showed you yesterday, the Old Mutual finds no increased evidence for early mortality and a cholesterol below 7.5. So these values are not grossly elevated. But let's say a person trained conventionally believes in the lipid hypothesis, the diet-heart hypothesis, they see this value. They would say, okay, this group is at risk of heart attack because their cholesterol is elevated. We must treat them with statins and we must put them on a low-fat diet, i.e. a high-carbohydrate diet. And that would be the exactly wrong advice.
Professor, just for the record, can you just describe the correctly which figure you're referring to?
We're looking at the fourth quartile, the group that has the most non-alcoholic fatty liver disease, and they have a cholesterol of 5.7 with a standard deviation of 1.3. So that value under current treatment protocols, which remember these are protocols, a doctor would be perfectly justified in telling this patient he or she must eat a higher carbohydrate, low-fat diet and must be put on medication. And in my opinion, that is the exactly opposite advice they need, even though it's written and it's conventional. And the reason why it's wrong is because these people have non-alcoholic fatty liver disease, and what is causing their problem is carbohydrates, not fats, as I showed you in the last hour. So that any diagnostic protocol based on cholesterol is going to give you the wrong interpretation if you don't consider the role of non-alcoholic fatty liver disease. And so finally, this is the prevalence of metabolic syndrome, which remember is hypertension, abnormal glucose tolerance, and the atherogenic dyslipidemia. In this population, healthy people living in Belleville, it's 50% in the group that's least ill, and it's 65% in the group that is most ill. So in essence, 60% of the population needs a different diet. And these people have not been diagnosed with medical condition. And I'm very concerned that it might appear that I promote this low carbohydrate diet just for people with insulin resistance. The point is that the majority of people are insulin resistant, at least by the age of 40 or 50. And so we are talking about an intervention for the majority of South Africans. This is not for 5 or 10% of the population. It is for the majority. So my conclusion is that this group of Cape Townians is suffering from non-alcoholic fatty liver disease, hyperinsulinemia, and carbohydrate intoxication. Now, what dietary advice should they receive according to all the evidence I presented this morning? But what advice are they likely to receive on the basis of the conventional advice that is in the dietary guidelines? And I would argue that they will be given advice that will harm their health. And that is why I'm here, I repeat, because it doesn't take a genius to realize that you can't treat people with insulin resistance and atherogenic dyslipidemia and fatty liver disease with carbohydrates. And I will continue to make that statement for as long as I live. Now, we're told, for example, that HIV is the real problem that we face in this country. But the reality is that South African medical profession and the researchers have done a brilliant job in controlling HIV in ways that 20 years ago we could never have believed possible. It's been astonishing. Now, my argument is that if diabetes was a viral infection transferred by sexual activity or whatever, and it was still going out of control, what would we say? We'd say maybe we don't understand what we're doing. maybe it's time to re-look at it. And that's my point. But here now, let me show you this. And this is what they found. This is your relative risk of early death based on other measures of the extent of your disease. So these people would be the most sick, and those would be the least sick. And what it shows that if you go onto HIV therapy, after 60 months, your risk is back to zero. In other words, you can get normal medical insurance after 60 months of treatment for HIV, which is astonishing. It's a great tribute to my profession. Amazing job. And to the pharmaceutical industry and everyone, that a disease which we thought would paralyze the nation is now treatable. And that people, if they fall under these criteria, even if they're pretty sick when they start, are not going to be at an increased rating for their insurance. That is astonishing. But they also look at what happens if you have type 2 diabetes. Immediately your rating is twofold increased. So you have to pay more for your insurance. 12 months later, you have to pay even more. And at the end of 60 months, you've gone a whole category higher. So this shows us that our management of type 2 diabetes isn't helping. The patients are getting worse. And I'm not trying to criticize or anything, but that's the reality. Now we should be looking at it and saying, if we did it for HIV, why can't we do it for type 2 diabetes? And my argument is we can do it for type 2 diabetes. But if we're not going to see the light, this is what's going to happen. So my point again is, let's look at the evidence and be realistic and realize that we've got something that's out of control. We believe that HIV would be out of control, but we've controlled it. So now let's move on and tackle diabetes seriously and reverse it. And I've shown you that in the Western Cape, the disease is out of control. As was HIV 10 or 15 years ago. We brought that out of control. Let's do the same for type 2 diabetes. Now we're going to go back to the same paper by Professors Kruger and Forster about physical inactivity, and I'm not trying to disprove anything, or what I want to show you is how did we get the idea that the calories in, calories out model works? In other words, it's possible to eat less and exercise more and lose weight. And what are the subtle influences, and maybe they're not so subtle influences, that industry has interposed in the last 20 or 30 years to make us believe that we can eat anything we like as long as we exercise? And I'm going to show you something that I'm really proud of, because my colleagues and I have been able to expose in the last 6 months the way in which industry has very subtly, in fact not subtly, they managed to hide it, the way that they have influenced the science of weight loss in a way that is utterly unacceptable. And it was so unacceptable that they've had to acknowledge they were doing it and withdraw. And this I'm very proud of. But I'm going to get there by showing that South African rural populations are not inactive. That when you actually go and measure what they're doing, you find they're incredibly active. And everyone knows that. Go and look in the morning. Who's doing the exercise? It's people working to traveling to work. We assume that the people who work in our houses and look after us are less active than we are. It's not, they're more active. So let's look at that. So the conclusion that these authors drew, and they presented the data, and I'm not suggesting the data are wrong. They said, besides age and household income, physical activity showed a significant negative association with body mass index. In other words, those who were the least active were the heaviest. And maybe one of the most important factors affecting body mass index is an index of obesity among black South African women. Public health programs for the prevention and treatment of obesity among black South African women should include a component of increased physical activity, etc., 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 and they propose dancing. And that's really good advice. There's no problem with that. So they concluded women with higher incomes and lower physical activity were at greatest risk of increased BMI. Physical inactivity showed the strongest association with measures of obesity in this study. Now remember, we spent a long time talking about association, and association is not causation. And so therefore, unless you actually did an intervention to prove that when you made people do more activity, they lost weight and the population became lean, then you can isolate physical activity as the factor. But that wasn't done. This is an associational study, which is great. It tells us we've got a problem. They're not doing much physical activity. They need to do more physical activity. But it doesn't prove that it's the cause. So Ian Cook, who was one of my students, but who did his PhD in the Sports Science Institute at UCT under Professor Vicky Lambert, is now at the University of Limpopo. And he published this paper, which has completely gone under-recognized, which is astonishing, because it's the first time that the actual activity levels of people, rural South Africans, particularly adolescents, were studied. He actually went out and measured how much physical activity they were doing, using data loggers and counts, so that he count how many steps they took. So these are real data. He's not asking how much exercise do you do every day. It's actually measured. So it didn't matter if you told them you were a marathon runner. If you weren't clocking up the day's steps, you weren't a marathon runner. And so what they've concluded was the one. Both underweight, normal weight, and overweight, obese, peri-urban to rural adolescents were active to highly active on most days of the week. And then the astonishing finding, physical activity was directly associated with adiposity. In other words, the more physical activity you did, the fatter you were, the more obese. And that is contrary to every suggestion you would think. Recall, he actually measured their physical activity. So he concludes the present results are certainly not conclusive in any sense, yet they do provide some interesting anomalous associations in the light of the traditional energy balance hypothesis. In other words, the more activity you do, the leaner you should be, because they found the opposite. And this should at least suggest that other explanations might be considered as to why there is increasing adiposity in some communities where physical activity levels are very high and food insecurity and poverty are elevated. So what he's saying is we can't just continue to assume that because people are fat in this community, they're not doing physical activity. When we measure it, they're doing a lot of physical activity. And some of these women were walking 10 kilometers a day, which give you an idea of how much physical activity they were doing. So he says the investigation, remember investigating actual measurement of physical activity, inactivity, and sedentary behavior must move beyond the widely accepted unidirection causality, i.e. inactivity causes obesity, and consider the alternative hypothesis that increasing adiposity, i.e. getting fatter, especially in rural and peri-urban populations who are active to highly active, might be due to factors not related to energy balance, but rather, in other words, balance between energy output and energy intake, but rather to the diet quality and how you partition that energy. And what he's talking about, energy partitioning, is a well-described phenomenon in animal husbandry, that during growth and particularly in cows, for example, that they secrete more insulin, they become more insulin resistant under certain circumstances when they're trying to produce more milk, and when they're trying to produce more muscle, they partition the energy to something else. And so the question, this is the concept of energy partitioning. So when you eat particular foods, you may be partitioning the energy into fat tissue, for example. And that's the insulin hypothesis as we described it. So then he continues in the regard, this is agreement with another researcher in the area, that certain macronutrients are carbohydrates, fats, or proteins, those are the macronutrients, are overemphasized in the adolescent diet. Indeed, within the population that he was studied, the consumption of carbohydrate is very high and the intake of protein and fat is low. In the Dick-Harley setting, the data suggests that being obese does not deterministically result in lower physical activity. Remember, that's the idea that you become gluttonous and then you become slothful. Rather, obligatory subsistence requirements of physical activity, the work you have to do to stay alive, coupled with social and environmental factors, appear to override the purely biological endocrinological drives which reduce physical activity. So people are being physically active even though their bodies are telling them you're fat, you must do less activity, and that's provided that the integrity of the biological systems is not threatened. So they are doing more physical activity even though they're more obese, and that generally it's the reverse. We find people become less active as they become fatter. So he's suggesting that we have to look beyond this relationship of simply calories in, calories out. And it's the nature of the calories that are important to consider, and particularly in a population that is eating a lot of carbohydrates, perhaps we have to consider the role of carbohydrate consumption as being a driver of the high rates of obesity despite high levels of physical activity. Now I need to explain a few things. That when I started, this is to do with conventional advice, taking on conventional advice, and then seeing where industry fits in. And then I'll get back to high carbohydrates, high sugar diets, addiction, obesogenic environments. So it's a link moving from the biology of obesity and why we become fat, in my view, because we're eating too much carbohydrates. We're now moving over to the environment that we live in and why it makes it so difficult to lose weight in the current environment. And I have to take a slight detour to show you that the advice again might be unconventional, but for 30 years I fought this industry, the sports drink industry, and proved they were wrong. And I think that will lead into the way certain industries are driving the obesogenic environment, and we need to understand the way they're manipulating science. In 1981, I was faced with the problem that we had found this lady who had overdrunk during exercise and developed a medical condition, and for the next 30 years I fought conventional wisdom on how much you should be drinking during exercise. And the outcome was this book. But what I learned during the process is the key to this debate. It was that this industry had influenced the scientists and made their lives very comfortable by funding them. And they chose scientists who drew up the guidelines for drinking during exercise. And that is where the industry completely controlled what the information coming out to the public was. And I exposed that in one chapter, which the publishers said, this is so dynamite, we can't publish it. And instead, I gave it to a lady called Deborah Cohen. And Deborah Cohen took that chapter and put it in an article in the British Medical Journal, which is one of the top 4 or 5 journals in the world. And here was the paper she wrote. Deborah Cohen investigates the links between the sports drink industry and academia that has helped market the science of hydration. So I stood up against the industry who were marketing a science of hydration which was completely false. And that book I wrote completely showed that it was false. So that's my point, was that I stood up because I believed in the science, the true science, not the conventional or wisdom that was being taught. And the point was that conventional wisdom was entirely being driven by industry. They had determined what the truth was, and they were going to get it out. And so she wrote this: the truth about sports drinks. Sports drinks are increasingly regarded as an essential adjunct for anyone during exercise, but the evidence for this view is lacking. And I provided that in the book. Deborah Cohen investigates the link between sports drink industry and academia that have helped market the science of hydration. So there are a few of us standing up against industry. And my point was that I now understood how industry functions to get a scientific message out. And we as academics either buy into that model or we stand up against it. And that it is very easy to give in to the industry and allow them to ride over the health of the nations. And what I said, I'm not prepared to do that. And I was vilified and demonized, etc. for it, but in the end I was right. And now I want to show you the more recent development that has had even more widespread effects, global effects, that are the final outcome of only now becoming apparent.